My task today is to talk about the extra-articular deformities, and we get a variety of them. So, what's the challenge? So, we all know that the anatomical landmarks are altered. The traditional instrument may not be always applicable. The ligament balancing may be compromised, and then there are other issues like scars from previous surgery and previous implant. What do we chase when we do a knee replacement? We all know that we chase survivorship and prom, and we have had enough discussions in last yesterday about what is correct and whether achieving what we want necessarily leads to patient satisfaction. But one thing is guaranteed: if you leave the patient with an S-shaped deformity, I think that's the key thing when we talk about extra-articular deformity, is not to leave an S-type deformity when you are doing these knee replacements, because that will certainly lead to unhappy patients. So one mantra that you want to take away when you are correcting is don't leave them with an S-shaped deformity. So what are the decisions to be made? There are three important decisions to be made. Whether you want to do a corrective osteotomy or you want to correct them within the joint. Number two, whether you want to do it one stage or two stage, and which technology to use. I think these are the three fundamental things when you look at an X-ray, you decide. Now, how to achieve all of this is to first define what is extra-articular, how much is the deformity, and why has that deformity occurred. So all these three fundamental questions when you look at the X-rays, you define. So how do you define extra-articular? Any one of you? I'll keep it interactive. Maisha, how do you define joint? You do both arthroscopy as well as arthroplasty. So understand the fundamental difference. That for a deformity correction surgeon, it means a line. For a scopy surgeon, it means the area within the capsule. And for a replacement surgeon, it's a box. While it's a line for a deformity correction, it's a box for us. And this we published in our paper in JBGS, where we actually defined what constitutes extra-articular. People talk about extra-articular deformities, people talk about constitutional violence, but less and less people have an understanding of what constitutes an extra-articular deformity. And this is the box. So when you're doing a joint, the area between the SMCL on the medial side is what is joint. And you must know what is that area. So if you look, it's 3 centimeter proximal and 6 centimeter to 7 centimeter distal on it. So anything that is there between this area is your area of field. This is where you can play. So once we understand that, and we did this study further to understand where are the deformities. So in our studies, we found both femur, tibia, and of course the joint line contributing to the whole thing. And there were 14 cases which had native deformities outside the joint. So you have to understand that there are certain people who have got deformities, 14% of them, or 1 in every 8 patient will have a deformity which is outside. So when we look at decision making, I think this is the key. The decision how to do it. So there are 4 options. The number 1 option is to do 2 separate surgery, correction at Cora and do TKR at second stage. The second is to do 1 surgery but at 2 sites, connecting some deformity at Cora and some with your bone cuts. Then there is 1 surgery, 1 incision, but at 2 sites. You do it through the same incision and correct both intra and extra-articular correction through the same incision. And fourth is 1 surgery, 1 incision, and correct all at same time. So if you understand this, this is what is the crux of the whole talk. You need to decide. And then the execution, of course, then execution, most of us will know how to execute. But if you go wrong in this decision or making the wrong choice for the right person, it will be doomed. Make the right choice. So 4 options. Before you go into the patient, you need to know what you are doing. So when do you choose option 1 and 2? The staged procedure versus 1 stage procedure is a personal choice. So if there's a large deformity away from the joint, it has a significant rotational component, especially when you have a femoral deformity, you choose the option 1 and 2, which is either 2 separate, meaning 2 site surgery. Okay, so if you have large deformity, rotational component, more of femoral side, do 2 site surgery. Doing it staged is surgeon preference and patient comorbidities. Option 3, which is like this: you have large deformities close enough to the joint, you have to do this. You have to use the same incision, use a plate, always neutralize it with a plate with this. This is how you do it. On tibial side, this stem may suffice, but you can do this. So it's better to do it with technology, and this is how you can do it. Through the same incision, you can put the stem extender, you can put a plate, always put a neutralizing plate there. So when you are doing it close to the joint. Now, fourth is how to do it when you're doing it both within the joint with TKR. And I think for that you have to understand that 2 criteria need to meet. and I've taken this from Mahesh's talk because it impressed me a lot, is this. One, that it should be within the box. This is the number one criteria I told you, that it has to be in the box. And number two, it does not have to be large enough to go away from the joint. So if you are drawing a line which is going away from the joint, that means that your ability to correct it within the joint is limited. So only correct it when you have both the criteria, that your deformity is primarily between that 10 centimeter zone of the joint, 3 centimeter, 7 centimeter, and when you draw the line, it is within the joint. If both of these conditions are met, you do the TKR and you correct all the deformities inside. Of course, option 5, I did not mention about it because it's too confusing, is to leave a residual deformity. And there is so much talk whether it is acceptable or not, and the jury is still out, and everyone will have it. But it's very interesting because this is from our own study where we plotted how it is. So as a continuation of that study that I did to find out extra-articular deformity, we also did how the CPAC classification changes. And you'll see that in this also there are significant proportion who have the extra-articular deformity, have lived all the life. So there is some merit in leaving a residual deformity. That's your option number 5. Now coming to what really, so we have understood the principles. The first thing is principle. I think that's the 80% of the job. Once your mind is clear what to do, then how to do will follow. And I think these are there has been enough debate on robotics and other things, but I think one area where I have absolutely no doubt, there's no marketing here, is that this is where the technology really plays a role. Either of those, PSI handled conventional or robotic. It's very ironical that I've written conventional navigation there, because normally they had conventional versus navigation, but navigation now has become conventional because robotic has become a stepping stone. So these are 3D printed jigs. You can just do that. You can order them so that because if your landmarks are altered, you have time to plan pre-operatively and you can use these jigs. You can use these handheld navigation like ISS from Zimmer. And of course, robotic and conventional navigation are where the real thing lies. I think one of my images are missing here, but this is the case example. If you look at this and then this, I think most of us will feel that these are significant deformities to be tackled in this. And you'll see how robotic helps in this. So these are the graph that I got on the right side. You'll see a very limited range of movement, very different kind of pattern that you get. And this is how the implant planning changes. So you can change the slope, you can change the flexion, you can change the rotation, and this is afterwards. So using robotic, we've used the 9 poly with minimal resection, and we have got this reasonable alignment. And then this is how it looks. It looks 2 degree, and the opposite side is 31 degree valgus. So in that stage, we remove the plate, we remove the nail here, and this is the deformity left. And obviously the patient was happy, so she came back for the second side. Again, much more challenging. You have got tight flexion gap. So again, when you look at balancing, you have to look at 4 corners: posteromedial, posterolateral, anteromedial, anterolateral. So here, if you look at both of these are quite tight. Anyone who wants to take, we have time here, so we can ask the question: what will you do? What will any of the conventional or navigation or even conventional instruments people will do? If you get this kind of graph, what can be done? Anyone who wants to Mahesh?
This is the
pre.
This is tight, or this is
so
tight?
anything below is tight, anything above is loose.
Yeah, that is the problem. Anyway, you are using some robotic, you see other screen, you have no clue what's happening.
Okay, yeah. So anything below is tight, anything above is loose.
In flexion gap it is tight, in extension gap only the lateral is tight. So it is, you can actually do lots of things. You can actually shift the femoral component up, or you can actually go from posterior to anterior referencing and increase your flexion space to accommodate the tightness in flexion. But there is differential tightness as well. So there is more tightness on the lateral side as compared to medial side. You can put the tibia a little bit into valgus, 1 or 2 degrees, and then you can change the femur, and then you will end up doing some releases.
Yeah. So the key point here is to look on the normal corner. So you have a large valgus deformity, you look at the normal corner and you want to get. So the only corner that I'm worried about will be because this is a valgus deformity, the orange part. So the thing that I want to get is that 4.7 should become 0. And how do you do that? How do you increase the gap on posterior medial side? Either increase tibial slope, increase tibial cut, or anteriorize the femur. So all of those you can be used. And eventually we did this, I balanced it out, and for lack of time I will not go into this, and I accepted a 3 degree valgus, which is my negotiable parameter and non-negotiable for this. And if you look at the whole curve and the post-op X-ray, this is how it is. It says 3 degree, I got 5 degree valgus, on the other side it's near neutral. So all this could be possible with a 9 poly without any significant release. All that thing that we heard in last talk, we did not need to do anything despite it be a 31 degree deformity. So again, a true case, but we don't have time for it. This one we did one side with the eye assist. The patient was happy, came back for the second side. We did the second side robotic assisted. So the key is the planning is the key. Decision making is half the job done. Choose between 4 options and use technology for execution and keep implants, adequate implants, which could be stem, plates and graft. Thank you.